Merci, Frédéric. Since the outbreak of the COVID pandemic, since all assemblies and congresses have had to adapt to what is now called virtual meetings, a custom has now been developed by those who know ESO and our desire to regularly share knowledge in all disciplines in the realm of esophagology. And so we have made it a habit to meet monthly, still in a virtual way, to discuss a case, a patient file chosen for its educational interest. This choice is now entrusted each month to one of the 18 pilot centers of the Platform of Excellence in Esophagology, which you see behind me, created by ESO with Stanford-SEMPIRE and Stanford Medicine. These 18 centers are located in the 5 parts of the world, and this network now represents a great standard of polydisciplinarity in the international scientific community. Today, it is for another time the Bordeaux Center, the OESO-SEMPIRE Hospital in Pessac, which is in the spotlight. At his head, but carried out on the best professional continuity, Professor Caroline Gronnier, who now has the difficult responsibility of prolonging in the field of surgery the work of the one who accompanied her daily for many years in the department of surgery, Professor Denis Collet. Here he is, who now, as I think, from time to time, leaves his sailboat, the Minaret. Thank you, here he is, and even his boxing gloves to come back with Caroline to Pessac and talk about the esophagus. In a few minutes, they will present the difficult case for which, as usual, a prestigious team has been gathered. Look, George Triadafilopoulos, here he is, who does not need an introduction. He, the honorary president of ESO, he is a close friend for decades now, and he, one of the most powerful drivers of our organization's initiatives. At his side, Professor Guillaume Piessen. He also a symbol of excellence when it comes to esophageal surgery, and which extends Christophe Mariet's influence from the city of Lille in the north of France. Professor Bruno Zilberstein, one of the faithful representatives of ESO, who had a very, very high-level multidisciplinary team in São Paulo and has actively contributed for many years in previous congresses and to another clinical discussion some time ago, as did Professor Richard McCallum. He also, even from El Paso, you can see him here, one of the pillars of ESO, and since our very, very first years. Is a very high specialization in digestive motility, and particularly in that of the stomach, makes his contribution to today's discussion particularly expected. Well, this is today another difficult case which combines several problems, those of treating esophageal cancer, with those of achalasia and significant gastric motility disorders. And I am sure that many of you in the audience will want to contribute to the discussion, which once again promises to be very exciting. I hand it on to Denis and Collet.
We would like to discuss with you today the case, a very difficult case of a young patient who was 48 years old at the beginning of this story. And it began with story episode of dysphagia that she experienced for 30 years. She weighed 46 kilos. I have to remind this figure because there will be a lot of changes during the history, and the body mass index was 17 kilos per square meter. You imagine a very a rather thin young lady. She had a high resolution manometry, which demonstrated a characteristic type 2 achalasia with, with a very weak esophageal motility and no opening of the distal sphincter. Therefore, she was scheduled for endoscopic dilatation, which improved her symptoms, and she gained 5 kilos. During the last session of the dilatation, the endoscopist could see a short superficial lesion, 18 or 20 millimeters in the mid-third of the esophagus. He did a biopsy, which demonstrates proved squamous cell cancer. Then she had an endoscopy, and on the endoscopy, the ultrasound endoscopy, which couldn't see the limit of the lesion. There was no lymph node, and the lesion seemed to be very superficial and could not be accurately analyzed. Therefore, we would like to ask to the audience, what would you recommend at this step? Any people, some people have some comments or some answer, reply to my question?
Denis, this is George. I have a few comments to make for the audience.
Yes, please.
The first one is, obviously, do you think that the weight loss is related to the lesion that you saw, or is just a serendipitous finding on endoscopy that was done for surveillance? It seems that the endoscopy was done because of the weight loss. Is that correct?
No, endoscopy was done only for dilation.
I see. Okay. Do you follow in France a protocol in which you follow these patients with long-standing achalasia with surveillance endoscopy? And do you think that there is a value to that endoscopy in terms of picking up these relatively early lesions like this one?
Yes, there is but at least it is usually recommended, but I fear that it is not very frequently performed, and I think that a lot of patients with achalasia are not regularly followed by endoscopy.
What is your usual protocol when you evaluate these patients? Because typically they have a significant degree of retention of fluid or food in the esophagus. Do you, in general, keep them without any food or liquids for a few days before they undergo this endoscopy, or you just depend on aspirating the material in the esophagus?
I think it is only aspiration, but I am embarrassed to answer because as a surgeon, I am not very aware of the endoscopic techniques for this kind of examinations.
Because it's very difficult sometimes to identify these early lesions of early esophageal or typically squamous cancer if you have a poor preparation. So it is important to do this step, in my opinion, at least like as an endoscopist. I think it is very critical to take this into consideration when you do this surveillance endoscopy or endoscopy for clinical purposes. So I think that's important for our audience to consider that if you're going to do an endoscopy in these patients, it will be very important to ensure that the esophagus, particularly in cases that there is a mega esophagus, to do everything possible to get a good look, either by preparing the patient a bit more differently or more aggressively than the standard endoscopy, and also to make the best effort to aspirate the contents of the esophagus.
Yeah, it's a good point, George. Good point. Could I ask you a question? You're saying endoscopic ultrasound was done and no lesion was identified. Is that what I heard? Am I turned on? Okay. Yeah. So was EUS done and there was no lesion identified?
Yes, that's what they said.
I see. And at this point, you've done no other imaging studies of the esophagus. You haven't done any other imaging studies of the esophagus except EUS.
We had only US and we had no, as you say, we had no imaging.
Well, I think most people would follow up with some, if you couldn't see it endoscopically, despite what George has recommended, I think most people would move ahead with probably CT imaging at that point.
Yes, the endoscopic ultrasound helps with the detection of lymphadenopathy, but the CT scan, which we usually do a lot in the United States, helps with metastatic disease, with the detection of metastatic disease. There are two important differences here. The EUS is helping with the detection of lymphadenopathy around the esophagus and looking for local involvement, while the CT scan helps with metastatic disease, either in the chest or elsewhere. Elsewhere would obviously be picked up by PET scan. These are important questions because if you're going to follow the endoscopic route, you want to make sure that the endoscopic ultrasound does not show any abnormalities that would disqualify the individual patient from a local resection, such as either endoscopic mucosal resection or endoscopic submucosal dissection. The superficial lesion that is described in this case is borderline. 18 millimeters is very close to 2 centimeters that we usually use as a differentiation point to perform an ESD, endoscopic submucosal dissection, as opposed to endoscopic mucosal resection. So the process here, assuming that the ultrasound was negative, as it appears to be for lymphadenopathy, the next step from the endoscopic perspective would be to perform an endoscopic submucosal dissection.
Thank you. That's what we did exactly. And an endoscopic removal submucosal dissection was planned in June and failed due to the fibrosis, and the endoscopic was unable to find the right plane of dissection. And after several attempts, he decided to give up and to say that endoscopic removal was impossible. Therefore, we discussed again together, and this lady was planned for an Ivor Lewis procedure. Would you have done otherwise? Would you have some suggestions or some comments?
I'd like to put a question. Would you perform before all of that of any resection? I do think that in this case, with a megaesophagus, dysphagia, and then a cancer, we should perform an esophagectomy. But before that, would any one of you perform a PET scan to define better the lesion and also to see if there are lymph nodes or the spread of this lesion, in spite of being a very little lesion? We like very much to perform PET scan because the sensibility and sensitivity of this kind of examination, it's very nice. So I would like to know if anyone could do that.
Yes, from my point of view, I think it's true. This lesion seems small, but CT scan and PET-CT are mandatory before going to resection in order to be sure that there is no lymph node involvement and no big tumor. Because I don't know what is the explanation of the failure of endoscopic resection. Was it a submucosal dissection, Denis, or just?
Yes.
Okay.
Yes, and he couldn't achieve it. And she had a CT scan. I do not remember if she had whether she had a PET scan, but she had a CT scan, which was quite normal. And our interpretation that she had an achalasia with a chronic dysphagia with a lot of episodes of blockage, and they were associated with a very superficial lesion, which couldn't be removed by endoscopy. And for us, it was an indication for going to surgery directly after a negative workup, negative preoperative workup.
Was there an attempt to biopsy the lesion at some point during this endoscopic assessment, either at the time of the submucosal attempt or at some point? Did anyone try to get a piece of tissue?
Of course, the lesion has been biopsied at several times to confirm a squamous cell cancer, and several biopsies had exactly the same conclusion.
What?
She had a very superficial squamous cell cancer.
Okay.
So you went for surgery, but then 2-stage or 3-stage surgery? Maybe I don't know if it's a question or not.
Yes, we did. Is it a question or?
It's a question or a discussion, I mean, because
you're right.
For those kind of esophageal dysfunction plus the tumor, I don't know if everybody would do an Ivor Lewis for those kind of.
Maybe we could answer to the audience.
Lawrence Johnson, with a limited lesion, why would you not think about radiation?
Because yes, you're right. For us, radiotherapy is only performed, exclusive radiotherapy is only performed whenever there is a contraindication for surgery. And she's a young lady, and for us, radiotherapy was has not need to be considered, has not to be considered.
Okay.
And we did an Ivor Lewis procedure, which was oncologically, it seemed reasonable due to the site of the tumor, and an Ivor Lewis could achieve good margin resection. And this procedure was performed with a laparoscopy and thoracoscopy, thanks to our usual technique. And a very small thoracotomy to achieve the anastomosis. It was the pathology confirmed a T1N0R0 squamous cell cancer with no lymph node and a complete removal of the tumor. And this is the beginning of the problems, because after surgery, she had a gastroparesis, and oral feeding was very difficult for her, and oral feeding had to be delayed, and finally she could be discharged on the 17th postoperative day. In October, she was still very uncomfortable. She had repeated vomits, and an nasogastric tube was placed with an endoscopy, and this endoscopy shows large ulcers on the stomach at the site of the staple line. There was no fistula, no septic complications, but only mucosal alteration. She had then an endoscopic of the pylorus. You can see of the CT scan the size of the gastric transplant, which is very dilated and full of food, full of part of food.
Excuse me.
Yes.
How large was the gastric tube pull up?
It was the standard, our standard size, and we do usually 6 or 7 centimeters in diameter.
Yeah, we do a very thin tube. We do a 3-centimeter tube, but we can discuss later about it. But it seems to me that it was a very large stomach pulled up. So this with the
yes, we prefer to do large gastric tube, 6 or 7 centimeters, to preserve as much as possible intragastric vascularization.
But isn't that pulling up, creating some tension at the level of the diaphragm, and the ulcer was generated due to ischemic components? Because probably, I think, there's a fair amount of tension as you move the stomach tube all the way up to the proximal chest. Is that a factor? I don't know, I'm just an endoscopist.
I think there was no ischemia of the tube during, there is no, because whenever there is an ischemia, it is at the top of the tube, and in this case, the ulcer was not on the top of the tube, but on one side. And I don't think it is related to an ischemia. Guillaume, do you have some comments?
No, it's true that in the department, we were used to perform, I would say, large tube. I mean, 6-7 centimeters, I think it's large, but it's true that it has also been associated in the literature with a certain risk of, higher risk of gastroparesis. So maybe this could be a factor that could have influenced the postoperative outcomes of this patient. The second thing, and I don't have the answer, is that in our experience, some patients who have motor problem with the esophagus, when we operate them, then they have secondarily some problem with the stomach, meaning that you know, for some people who have achalasia, then we perform the myotomy either surgically or endoscopically, and then the patient come back and has a problem of gastric. I don't know what is the explanation, because after surgery you always think maybe I damaged the vagal nerve or so on. After an endoscopic myotomy, cannot be the case, in my opinion. So I don't know if you have such experiences, and I've never seen so much literature on this problem, but this is, an observation that we made in the clinical practice.
We have not so much patients with achalasia who had an Ivor Lewis, but I think this is your question is very important, and maybe the following of your story can be explained by a motility disorder of the stomach associated with an esophageal motility disorder. And I would like to ask to George if he has this kind of experience. He's a specialist on motility, digestive motility. And do you have any experience like that?
I will pass this question, Denis, to Dr. McCallum, because he's a pro at this, much better than I am. But from a perspective of doing an endoscopic myotomy to treat the achalasia, there is a possibility, as was mentioned, for the formation of a problem in the stomach vis-a-vis vagal injury. And if you do have that issue, then gastroparesis may be a factor in this. So, Richard, do you have any opinion here?
Yeah, thanks, George. Well, achalasia is not connected to a gastric motility disorder per se. They don't occur together. Pulling up the esophagus and doing this procedure is associated with vagal nerve damage. That doesn't happen every day, but in the best of hands, it happens, just like it happens during a fundoplication. It'll happen during a pull-up, as was done here. So this is all consistent with post-surgery vagal nerve damage, but it's early. It's early. And you could argue that with time, something good might happen, even though the stomach is very dilated. Damaging the vagus nerve shuts down the pylorus. It cannot relax. And that's been obviously well established. But this is immediately or soon after surgery, day 17. So you can argue that maybe some of this post-vagal nerve damage is not as severe as this stomach dilation would imply. And patients probably on narcotics and pain meds post-operatively, which is also inhibiting gastric motility. Possibly being around the diaphragm is also compressing the pyloric area a little bit. So the game would be to buy time and see whether there is any improvement. Although at the situation you're in now, you're going to have to do something to maintain nutrition. A nasogastric tube is not going to do it. So probably at this point, you tried to dilate the esophagus. How was the esophagus pylorus dilated? Was it dilated with a through the scope balloon, or how was the endoscopic dilation of the pylorus approached?
It was done with a balloon. It was a balloon dilatation of the pylorus endoscopically, and during the endoscopy there is low stenosis, particularly at the site of the crura, of the diaphragmatic, of the hiatus. And we expected a lot of improvement, but unfortunately it was not very efficient, and she was still unable to eat easily, and we had to place a jejunostomy surgically. And she again, sorry?
Yeah, that's a good decision. A 20-millimeter balloon through the pylorus does nothing. Does nothing. It's interesting, but unless you've got a pyloric channel also or something, it does not help post-vagotomy pyloric damage. So you made a good decision. in placing a surgical pyloroplasty, a surgical jejunostomy. I think that was a good decision. So you went down 2 or 3 feet or more beyond the ligament of Treitz. Is that correct?
Yes.
What do you consider about a 30-millimeter balloon for the pylorus?
You know, Medtronic, if you want to get fancy, you'd have to do endoflip. You can't just do this by a prayer. This is beyond prayer. You have to have some kind of objective evidence. So
Yeah.
we would probably do endoflip.
But there's very good evidence that the 30-millimeter balloon prevents further problems on emptying of the interponate.
There is some early data from Medtronic. They have this balloon. And if you blow it up slowly to 30 millimeters, at the same time, you do endoflip. And if you show that the diameter and pressure characteristics of the pylorus can be changed by going to 30 millimeters, that is fine, but that's very early. That's a Medtronic wish list. I don't think anyone has proven that at this point.
There's some data out of the Cologne Center from Hölscher who showed that you can prevent further or you can treat the delayed gastric emptying with a 30-millimeter dilatation postoperatively for nearly, I think, with a very good treatment option. But I think this is maybe a good discussion point. But
it's a good discussion point, and I totally agree with you. With a 30-millimeter balloon, we have very nice results. But I have to insist that when we have a dysphagia problem due to a achalasia, in 50% of the cases, the stomach is damaged also. So it has the same problem of the pylorus impact. So we should perform something on the pylorus anyway.
Well, these cases you're talking about, cases that went to surgery where you performed a limited helemyotomy and a loose wrap, because the standard achalasia case does not involve the stomach, okay? Does not. If you manipulate the esophagus and do something, as in surgery, you might and then get involved with damaging the vagus nerve. But the de novo achalasia patient does not have a concomitant gastric motility problem.
Okay. And the difficulties are still going on. And in January.
Now, hang on. Did the J tube fall out, you're saying?
Sorry?
Did the jejunostomy tube fall out? It fell out or it failed?
It failed. It fell down 2 months later.
It fell out or it failed?
It felt.
The patient pulled it out?
Yes, right.
That's unfortunate because jejunostomy feeding tube is a very, very good approach to maintain nutrition. That's unfortunate.
But the patient didn't accept it very well. And I don't know what happened, but one day the jejunostomy had disappeared. And it was very difficult in January. Some months later, the weight was 34 kilos. And she refused another jejunostomy, and we placed another gastric duodenal tube for nutrition. And
can we go back to this endoscopic submucosal pylorotomy? Is this the G-POEM procedure? Is that what you're referring to?
I think so. Yes, it's a gastric poem. Yeah.
And did you do any endoflip data before and after the G-poem was performed?
At that time, we did not gastric poem. We had not, it was not available in the department. Now we is possible, but it was several years ago, and gastric poem was not usually commonly performed by the endoscopics here.
Yeah, well, let me say that although G-poem's getting a lot of press and it appears to be sexy to have in your unit, the amount of good data on it is negligible. If you want to do a serious pyloroplasty, which this patient needs, the patient needs a surgical pyloroplasty. G-poem is an excuse for buying time, and you may get lucky. Right now, G-poem has very little objective long-term outcome confidence level. If I had this problem, I'd want a surgical pyloroplasty.
But our concern when you do a pyloroplasty is the biliopancreatic reflux and the risk for the stomach and for the ruminant esophagus. And we are not very in favor of pyloroplasty, whatever the technique, endoscopic or surgical or surgery, to preserve the stomach and the ruminant esophagus.
What are you saying about preserving the stomach?
She refused another jejunostomy, and she there was a big problem, a nutritional problem. And the first way, the best way for us was to place another gastric duodenal tube, and we could check at this time that the ulcer were improving. They were not completely healed, but they were improving.
Yeah, but that's a very short-term solution. No one can live with a tube in their nose more than a week or two. It's not going to work out.
I presume, Richard, that this is a traditional gastrostomy that is extended to a jejunostomy. I don't think it's a nasal. Was it a nasal intervention, or it was through a PEG, a traditional PEG?
Well, it's difficult to make a PEG after Ivor Lewis, so I think it was just a nasoduodenal tube.
Oh,
sorry,
wow.
a nasoduodenal tube. I understood this.
Oh, wow. Yeah, I understand the difficulties involved, but as Richard pointed out, the nasal gastric or nasal jejunal feeding is extremely uncomfortable, and it's not. I don't think it's going to last any longer than maybe 1 or 2 weeks, even with the most compliant patients. To make another point, to expand on Richard's comments about the G-poem, here we don't really have good data because of the fact that the patient had an Ivor Lewis surgery, and we don't really know what happens with either a classic myotomy or a G-poem, because we have a significantly distorted gastroesophageal junction. So you may have a patient who may have actually duodenal content coming up into the stomach conduit, and that creates a significant intolerance. And then maybe the patient did not like what she was experiencing because of the combination of duodenal gastric esophageal reflux, which is a significant challenge for these patients.
So Denis, if you were now in 2021, you wouldn't propose a gastric poem for this patient? Because you said you were reluctant to propose those kind of intervention because of the fear of duodenogastric reflux, right?
You can propose a G-poem as step 1 in the post-operative course when the patient is still recovering and still not perfectly sort of ready, perhaps, for another surgery. But don't hold your breath. It will not be a solution to anything. And down the road, the patient will need a surgical pyloroplasty to resolve the question. You can maintain nutrition while you wait for her to be stable.
Another thing that I find useful is the fact that under the circumstances, if you perform a HIDA scan, you may find by nuclear medicine technique that the bile comes up all the way to the proximal esophagus. And I think that would be a useful tool to identify the presence of duodenogastric esophageal reflux. And it may help you to consider medical therapies such as bile acid inhibiting therapies like cholestyramine, for example, to reduce the burden of the bile acid reflux, including sucralfate, including proton pump inhibitors, and a variety of other medical treatments to improve the general feeling of feeling better. So these are all medical tricks that Richard and I are using, I think.
So the aim of the clinical case was to discuss about the difficult case of delayed gastric conduit emptying after esophagectomy for cancer, which is associated with adverse outcomes and troubling symptoms. Widely accepted diagnosis criteria and symptoms grading tool was missing. An article that you can see just here was published in Disease of the Esophagus in 2020 using a Delphi process. And it was then possible to divide the delayed gastric conduit emptying into early, I mean, if the symptoms are present within 14 days of study, which was the case for this woman, or if there is a late gastroparesis. So the final criteria for early delayed gastric conduit emptying was more than 500 milliliter of duodenal nasogastric tube output measured at the morning of postoperative day 5, or more than 100% increased gastric tube with on frontal chest ray projection. So the patient, she was feeling the two major symptoms. Do you use also the classification to define gastroparesia?
Caroline, we don't see your screen. Well, I don't see it at least. Is it still shared or?
Ah, sorry. Okay.
Thank you.
So my question was, which definition do you use for gastroparesia?
You mean after esophagectomy?
Yes.
As the one that, that has just been shown, no? Because it's the consensus, international consensus? No?
You're saying you're not sure that you'd use the standard meal tests. You're saying the patient cannot even eat a small meal to measure traditional radioisotope gastric emptying. Is that one of your questions?
Yes, it was.
Well, I think you try to have the patient eat a small meal. That's what is done traditionally. A small isotope labeled meal, 350 calories, 250 calories, small meal, and they could maybe finish half the meal or try to finish the whole meal. And you take a series of images, just like we normally do. I don't see any unusual reason why this patient wouldn't be subjected to the same test. That's what we do. And in talking about gastroparesis, that it's not due to pyloric stenosis. If it's due to pyloric stenosis, then obviously nothing will happen. But you've already done endoscopy, and you've shown that there is no pyloric stenosis. The scope can go into the duodenum. So this patient would undergo a standard radioisotope gastric emptying test. There's no there's no reason to change that plan.
To enhance what Dr. McCallum mentioned, well, first of all, there's some kind of an interference, so we cannot hear very well. Everybody's muted. Frederic, can you mute people if you can?
Yeah, sure. I'm not sure where the problem is coming from.
Okay. Anyhow, to enhance what Dr. McCallum mentioned, I personally think that all these are interesting research studies that I don't know if they have clinical value, to me at least. If it's early or late, how do you define these things? To me, is not that significant. What I actually wanted to emphasize here is that gastroparesis, and Richard, correct me if I'm wrong, has two elements. One is the motor element, and the other one is the sensory element. So if we're dealing with a person who has intolerance because of the non-distensibility of the stomach or increasing amount of sensitivity, if you will, of gastric fullness, that may also play a role in the induction of the symptoms of gastroparesis. So you may fix anything you want, emptying or traversing the pyloric channel, and you still may have problems with the distensibility or the poor compliance, if you will, of the gastric remnant below the diaphragm. So all of these are elements that are interesting, at least in my view, from the academic and scientific perspective. And we need to consider all these issues playing a role in the patient's food intolerance. And I wanted to bring that up for a discussion with the experts.
Well, vagal nerve damage, as you know, George, and it's not just a pyloric thing. The left vagus nerve is damaged. The left vagus becomes the anterior vagus. And the anterior vagus supplies all the stomach and duodenum. It's not just pylorus. And so the stomach is weak and the pylorus doesn't relax. So, you know, you would try to treat this patient with the standard menu of prokinetic drugs. You wouldn't just, you know, move into another surgical procedure. You would move into standard gastroparesis therapy to buy time, including even Botox of the pylorus, which is similar to J. Pasrica's original work on achalasia. This is pseudo achalasia of the pylorus, where the pylorus does not relax due to vagal nerve damage at surgery. So, you know, this patient needs to be exposed to the usual menu of prokinetics and antiemetics and even Botox, and buy time and see if you can improve the gastroparesis. That can be monitored by doing gastric emptying tests, eating an egg meal, and measuring how much isotope is retained at 2 and 4 hours, and then giving a series of treatments and seeing if you can objectively improve gastric emptying, as well as hopefully improve her symptoms.
What I was referring to is the element of poor distensibility of the stomach and the poor compliance that causes a hypersensitivity to the patient. Yes, I do agree that the pyloric channel, if you will, is compromised, does not open, as you said. And there are prokinetics, there are, you know, a variety of endoscopic tools as well as surgical tools that we have. But the issue that I wanted to bring up for discussion is the possibility that we may have a sensory issue with this patient, and agents like buspirone, for example, may play an additive role. And I also do agree with you about the optimization of the use of antiemetics that may actually make the patient more tolerant to even a dietary modification and allow her to gain weight. So I think that's all of these components are important and go above and beyond what surgical interventions we could offer this patient.
Yeah, the vagus damage impairs fundic relaxation.
Right.
So Buspar has a role there, but motility throughout the stomach is impaired. So there's a role for the metoclopramide. There's a role for the 5-HT.
I think that the problem is not localized only at the pylorus channel.
No, it's not
but
just pylorus. It's not just the pylorus, but
it involves all
it's
the
not
gastric
sensory.
motility.
It's not sensory, George. The whole stomach is weak. The fundus may not relax.
I agree.
But the antrum does not contract. And
Exactly.
that's not sensory. That's vaguely driven.
And this is the following story. Thanks to the nasogastric tube, she could gain some weight. And the nutritional status was improved because she reached 45 kilos. She could eat. It was not very comfortable, but she still complained of vomiting, reflux, and coughing at night. And an endoscopy could check that the ulcer has totally healed. Then she had an X-ray control, and you can see the stomach, which is very dilated. And at that time, the situation was still was not very good. It was very bad. Of course, whenever she had CT scan, endoscopy, or whatever, we could check there was no problem of cancer. The problem was not oncological. The problem was only functional. And at that time, we could propose to her a duodenal diversion. We even talk about a colonoplasty, which had the advantage to remove all the stomach and place a piece of colon, place a jejunostomy, and maybe would you have other solution to propose? Of course, she had all the treatment to stimulate the gastric motility, such as praperan and erythromycin, which were not efficient. Would you consider a coloplasty or a duodenal diversion?
I do think that duodenal diversion won't work because the obstacle is the pylorus. So if you diverse the duodenum, the stomach won't end. So it's a very difficult operation because you have only two pedicles that give the irrigation of the stomach. The right gastric artery and the right artery coming from the pylorus. So,
I agree with you, Bruno, and we will present at the end of this paper. We will present a short series of 9 duodenal diversion after Ivor Lewis, and there was no problem with the vessel thanks to some technical details. But would you consider a colonoplasty?
It's not a bad procedure, but it's a very big operation. You have to remove the stomach and to pull up the colon. It could help, and put it in the neck.
Sorry?
It's not a bad idea.
Not a good idea.
Not a bad idea.
Not a bad idea, yes.
But it's a very hard operation. You have to remove the stomach and then to pull up the colon retrosternally to the neck. You have to do a lot of operation in a very weak patient after so many difficulty in eating and losing weight. So
yes, I agree. But we've done one or two times. It's feasible. It's difficult, but it is feasible. But for us, there were two problems. First, she was not very crazy about the second very big operation.
I can imagine.
And I understand why. And the second point, that she has a severe motility digestive problem. And I don't know whether or not the motility disorder includes the colon.
Yeah, you're right.
After a big operation, we could take the risk that of an inefficient operation, and I think for me it was not reasonable.
Maybe a Roux-en-Y gastric diversion without touching to the duodenum. Yeah, maybe this could be an option, you know, because it's the irrigation of the stomach. It's very dangerous. So maybe a Roux-en-Y diversion of the antrum could help a little bit.
Do other surgeons have some opinion?
Denis, well, in our experience, I think we would have proposed Roux-en-Y diversion if there is really no problem on the pylorus, which seems to be the case in this patient, where you already open the pylorus and there doesn't seem to have problems on the pylorus. Otherwise, we already did duodenal diversion. Professor Triboulet learned this to me, but I agree it's not so easy. Well, it depends where is the pylorus, because if the plasty has been is high in the thorax and the pylorus is really high, sometimes it can be difficult. Coloplasty is probably a good option, as Professor Zilberstein said, but it's a very radical procedure. I think it can be kept, you know, just in case all the other solution wouldn't work. Okay, so it's an extreme solution that can be considered, but after you tried something else. We recently had a case where we were about to perform a coloplasty because we made a Roux-en-Y and it failed. And in fact, during the operation, we had many problems with the lunge, because of the dissection that was very hard, you know. And the anesthesiologist told us that for them it would be complicated to go for the coloplasty after we had mobilized all the gastroplasty. And so we chose an intermediate solution, which is to to replace, I would say, just dissect all the gastroplasty and to do a new tube with a gastroplasty and a new esogastric anastomosis. This has been described in the literature with several case reports with some favorable outcomes. And in the patient where we did this, we had there was a success, you know, on in the post-operative outcomes. We were very surprised about this, but then I saw that there was also other cases that were described. So I would say it's a fourth option in addition to what you propose in your slide.
You mean that you did a narrowing gastroplasty? You reduce the size of the gastric tube?
Right. Yeah, you dissect all the gastroplasty, because as you see on your radiography, your gastroplasty is very large and very. So you mobilize everything, okay, and then you cut and you pull up, and you do a new tube, which is less large.
Well,
I agree. It was not our first choice, you know, but we had a failure of the of the Roux-en-Y solution that was proposed by I don't know who, and well, the patient was asking us for a definitive solution because he had spent 2 years without eating, and with the COVID and so on, it was really hard for him. So we were ready for the coloplasty, but then we have to change our plan during the operation because of the lunch problem. Well, it's just an alternative, okay, to coloplasty. Okay.
I'd like to make a, I think you're all being way too aggressive. This is not a complicated case. Okay, it happens every day. And this patient needs initially a Botox approach to the pylorus, a brief trial, and then after that, a surgical pyloroplasty. That is the treatment for this patient. This other stuff, with great respect, you're way too aggressive. This woman came in as a pretty normal achalasic. Now you're turning her into a very complicated post-op situation. This is a case of pyloric dysfunction combined with gastric dysfunction.
Maybe my slides are not.
Post-vagotomy setting, the patient needs Botox. If that doesn't do enough in the first couple of weeks after you do it, even the first week, patients get better. Patient needs a surgical pyloroplasty.
Maybe my slides are not so clear, but for us, it was a very difficult case. It was a very severe condition. This patient was unable to eat some years after surgery. She was cured of her cancer. She had a very severe consequences of her operation. She had to stop her job. She has no social life because she was unable to eat a normal meal with some friends, with some people. And for me, it is a very severe condition. And you see that her weight dropped to 34 kilos. And we were very concerned by her nutritional status. And all the tubes, nasogastric tube, jejunostomy are for us only palliative procedure, but our problem was to find a solution to help her to resume the autonomy for eating. And therefore,
I totally agree. But did you try Botox? Did you do anything simple during this time?
No, we didn't try Botox. We did only 1 or 2 sessions of pylorus dilatation. And as I said before, I am very reluctant to maintain a wide open pylorus due to the risk of duodenogastric reflux.
We do pyloroplasties every week in the name of gastroparesis, and we don't see duodenogastric reflux. We don't see it.
Very good.
Anyway, finally, in March 2018, we decided to do a Roux-en-Y procedure, and you see the procedure. We place remove the pylorus, and we place the stomach on the Roux-en-Y loop. And of course, there are some technical difficulties. The first difficulty is to preserve the right gastric pedicle. And the second is to reach the pylorus or the pylorus area, which is very high in the abdomen, and it is very close to the hiatus. And we must be very careful for the dissection and to do this operation. Surgery was performed. Post-operative course was uneventful, but the weight was stable, 44 kilo, which is close from the initial weight, but not perfect. And oral feeding was possible, sufficient, but it was not very comfortable. And some weeks later, she still presented regurgitation and sometimes vomit. Therefore, we cannot consider a complete success of this surgery, at least in the beginning. And I leave the micro to Caroline, who had some comments for that.
Next slide. So I just wanted to talk about prevention. So I think we already talk about this this article in the previous discussion. This was a single center retrospective study of 115 patients. The aim was to compare the preoperative pylorus dilatation, and it was a 30 centimeters balloon dilatation, as we said before, and a total, and there were 13 patients in the group with a pylorus dilatation. And the rate of gastroparesis was much lower in the pylorus dilatation group than in the other groups. So that could be discussed to perform a preoperative pylorus dilatation. I don't know if that's your that's a technique that you usually use in your clinical practice.
I have used it. I have used it. The problem with this, first of all, the 30 millimeters is quite dramatic. This is achalasia type of balloon. I have used it with the standard through the scope balloons, which go to about 20 millimeters in diameter. The problem with a balloon dilation is that it does not last for too long, and it has to be repeated, sometimes every 4 to 6 months. And this is why I agree with Dr. McCallum about the approach of the, of the pyloromyotomy, although this one is now already a Roux-en-Y. So I'm not sure, what are you going to dilate after the surgery that you did? Are you talking about the gastrojejunal anastomosis? What balloon are we talking about here? This is balloon of the pylorus, right?
On
so
the pylorus, right, yes.
Yeah. So this is already, this patient has had a Roux-en-Y, correct?
Right. Yes.
So I'm not sure what you're going to balloon here. But be that as it may, I have used it, and I'm still using the approach of pyloric balloon dilation. Although going to 30, I think it's quite dramatic, but it can be done. The concern that I have is that the duration of the effect, and I don't know what this study was done and how quickly after they monitor their patients from the perspective of symptoms, from the perspective of gastric emptying, or how they measure things. I cannot read the, I'm sorry, I cannot read the specifics of the summary, if you will, because it's a very small font. But I would caution you about reviewing this paper a bit more carefully about how quickly they measured the gastric emptying, because early on, it would be actually a positive effect. But if you look at it at 6 months, I doubt that it's going to last.
I don't remember, but I think it was quite early indeed, as you said.
Yeah, yeah. It doesn't last forever. Nothing lasts forever, but this specifically, this issue, it's not lasting for too long. Maybe you have to repeat that if it works, you can repeat it at 6 months or whenever is necessary. Same thing with achalasia balloon.
On this slide, that's an article dealing with the use of post-operative pyloric dilatation for delayed gastric emptying, as we said before. And in this study, this was a retrospective study of 436 patients, and gastric outlet obstruction was found in 22% of the patients, and the pyloric dilatation were performed with controlled radial expansion with balloon dilatators range 10 to 20 millimeters. And the conclusion was that delayed gastric emptying after esophageal substitution with gastric conduit can be adequately treated with balloon dilatation of the pylorus. So for this study, it was in favor of pylorus dilatation. This
it was a 30 millimeter, or
it was 10 to 20.
10 to 20.
Yes, but indeed, as George remarked before, I think it was a very early evaluation.
Okay.
In this third paper, the aim of the study was to study the effect of pyloroplasty on gastric conduct emptying after Ivor Lewis. It was a retrospective study. In this study was compared the group with subjective questionnaires to assess the perceived quality of life. And the results did not show any difference between the two groups, between pyloroplasty or no pyloroplasty. So the conclusion of this study that was that the pyloroplasty was not associated with improved long-term outcomes. That means that we do not perform usually in clinical practice pyloroplasty during Ivor Lewis procedure. I don't know if you have the habit to still perform pyloroplasty.
Well, our surgeons favor that, and they prefer to do this at the time of the surgery, the original surgery of the Ivor Lewis procedure. I do not know how the data is presented in this figure here that you're showing, because obviously you need to have some objective markers of the assessment. If I have an Ivor Lewis for cancer, I will feel great because I know that my cancer is out. So unless you have some kind of a comparator group that you compare, let's say, to placebo or to sham procedure, the immediate effects of having gotten rid of your cancer because of the Ivor Lewis procedure have an impact on the quality of life. So I think the assessment has to be carefully done to exclude the possibility that the patient is favorably affected by whatever you're doing surgically as well as endoscopically. So I think that is an important element to assess in these patients.
Thank you. So this was quite interesting article that I found when I searched the literature preparing this case. It is two case reports of the use of electrostimulation for intractable delayed emptying of intrathoracic stomach after esophagectomy. It was placed in two male patients, aged 52 and 60 years, who underwent Ivor Lewis esophagectomy for esophageal adenocarcinoma and were dependent on jejunostomy. The relief of symptoms was persistent with no nausea or vomiting, and decreased total symptoms score from 12 and 16 to 6 and 9 respectively. And the conclusion of the article was that patient with intractable delayed gastric emptying after esophagogastrectomy may benefit from this device implanted through thoracotomy or through thoracoscopy. I don't know if you have any experience of electrostimulation for this kind of problem?
Yeah, we have a lot, and there's two comments. One, despite the early enthusiasm, electrical stimulation to stomach does not improve gastric emptying. There's no effect on gastric emptying. Its only role is to improve nausea. So it can be helpful to improve nausea, but currently we're doing electrical stimulation with a polaroplasty for gastroparesis. Electrical stimulation alone does not improve gastric emptying. So I think that this is interesting, but it's not accurate. And also Medtronic has a red flag about putting electrical stimulation, a few inches from the heart. And you'd have to be very careful about, we don't have any cardiac effects when you do electrical stimulation of the stomach. In the abdomen, you have to be a little careful in doing electrical stimulation in the thorax, but good for nausea, but you have to do a polaroplasty to change gastric emptying.
I agree with what Richard said, and I wonder how this was feasible next to the heart and in the chest. So I would like to have a bit more information about the feasibility and safety of this approach, which is completely radical, as Dr. McCallum pointed out, because it's sitting next to the heart, and it's putatively very dangerous to create arrhythmias. In my own personal experience with this approach is that even in the stomach, placed under ideal circumstances, it is not that dramatic. So I don't expect that it will make a significant impact. Now, having said that, Tom Abel, who is the senior author of electrical stimulation paper, is obviously a pioneer in this, as Dr. McCallum is, and maybe it's done under the best circumstances. I'm actually surprised that the IRB of this institution, which is in Mississippi, allowed them to do that, because it's experimental, and even the company does not recommend any kind of deviations from the mainstream approach. So it's interesting. And technically speaking, I wonder if the surgeons in the audience think that this can be done in the chest, assuming that everything else is okay, how feasible this is, because it's above the diaphragm. And it requires special, because this procedure is done with a combination of endoscopy. So I'm doing the endoscopy, the surgeon does the approach of placing the stimulator, which is obviously, as in this picture, goes below the diaphragm, but the electrodes, in this case, go above the diaphragm next to the heart. So I think that's kind of dangerous. And frankly, I would not take that risk. There it is. Is this what you did, or that's another paper?
That's another paper, but it's also dealing with the same procedure. It's only through thoracoscopy, and instead of the thoracotomy in the previous article, but we don't have any experience of that. I found it in the literature, and I wanted to discuss that with you.
Yeah. It does not really have very impressive effect on motility. It does have an effect on nausea in selected patients, but I'm not sure. They described this, that it worked for this patient that Luigi did in Milan. Did they describe that they had a positive effect?
What was the result, Caroline, of the?
Oh, as in every case reports, so it was visible, and at 6 months follow-up, there was a significant improvement in the total symptom score of quality of life. But it's quite a short follow-up.
Yeah, interesting, intriguing, actually.
That's only case reports.
Yeah. I don't see anything moving out of the stomach. Do you, Richard?
What's that?
Do you see any movement of that nuclear scan? I see that kind of everything stagnating up there.
Yeah, unfortunately, even Medtronic has given up, as you know, if you go to the DDW and the other shows. They are not promoting this stimulator anymore. We use it. A number of us are advocates, and we know its role, and its role is antiemetic. It's the most powerful antiemetic we have. It has a great role in the treatment of refractory nausea, vomiting, gastroparesis, but please don't expect it to improve gastric motility. It doesn't happen. So we have to be realistic.
According to the figure here, the legend says that they saw 30% decrease in radionuclide retention. I only have half of the sentence here, but to my assessment here, it does not really show any significant emptying. It shows that there's still stuff hanging out there. I'm not very impressed with this, by the way, just based on the my interpretation.
Go back.
of this.
Sorry.
What?
Let's go back to our patient.
Yeah.
Okay.
She had no stimulation, esothoracic or intra-abdominal. She had an UNI. At the beginning, we thought it was not a success, but an improvement. But she was not very good, and she started to lose weight again. And I had to convince her to place a jejunostomy. And in my mind, the jejunostomy was a definitive procedure who should help her to at least have a stable weight. And she organized her life. She could do all the things on the daytime, and she received 1 liter of oral nutrition during the night. And every day, at the daytime, she did 3 meals per day. And in last July, 5 years after surgery, after a constant fight against weight, or for weight, sorry, her weight was 49 kilos. She was able to eat by herself. I stopped the nutrition by the jejunostomy, and I will see her on next week, and I have planned to remove the jejunostomy, and maybe it will be the end of this very severe history. And for us, it was the problem of gastroparesis after Ivor Lewis. The duodenal diversion didn't meet our expectation, at least in the beginning. Maybe in the long-term effect, it will work, or it will work better. And we had done diversion in 9 patients, and we would like to show you very short results about our experience in Rouen after Ivor Lewis with varying results. And we will have time to discuss indications at the end of this session. Yes, this paper, this study was accepted for publication, and we performed, in 9 patients. In 9 patients, we performed a Roux after an Ivor Lewis in patients who had very severe difficulties for eating long-term after surgery. Of course, we propose this surgery only in patients who have no oncological problems, and when we are sure, or as far as we can, that there is no recurrence. The indications are reflux with a failure of medical treatment. You see, it is a short hospital stay, 8 days. Maximum was 34 days. I don't remember why, but it was not due to surgical complications. There was no mortality, and there was for no transplant necrosis. That means that we have not damaged the gastric vessel, which were identified at each time. And follow-up was 17 months. In 4 patients over 9, the quality of life resumed normal compared to a standard population. Some patients have no heartburn. 6 patients are sometimes regurgitations. 1 patient is not improved, and 3 patients are considered to have a complete regression of the symptomatology after surgery. In our experience, the problem is that we are unable to foresee the result before surgery. We have no examination, we have no objective test which can help us for indication and to foresee the improvement or not of the symptoms.
To go further, an article has been published in the Annals of Surgery recently. It was a randomized phase 2 trial, which aim was to compare gastric reconstruction with duodenal diversion plus Roux and Y anastomosis versus classical Ivor Lewis. 60 patients with thoracic esophageal cancer scheduled to undergo esophagectomy with retrosternal gastric tube reconstruction were randomly allocated to standard gastric reconstruction, 31, or gastric reconstruction with duodenal diversion in 29 patients. The primary endpoint was quality of life assessed by the AUGS 32 scores 1 year after surgery. There was no difference between the 2 groups on baseline characteristics. Pancreatic amylase concentration in the gastric conduct on postoperative day 2, 3, and 7 were higher in the non-Roux and Y group. And postoperative endoscopic examination showed residual gastric content in 7 to 17 patients on the non-Roux and Y group, but none in the Roux and Y group. And quality of life was significantly favorable in the Roux and Y group with regard to reflux symptoms and food patient passage dysfunction. So postoperative body weight changes and serum albumin levels and peripheral blood lymph nodes count was not significantly different between the 2 groups. And the conclusion of this article was that reconstruction with duodenal diversion plus Roux and Y was effective in improving both gastroduodenal reflux and delayed gastric emptying. So what do you think about this attitude to perform Roux and Y diversion in prevention of gastroparesis?
Bruno, would you systematically perform a Roux and Y at the time of an Ivor Lewis? We do not hear you, sorry. Could you switch on? Yes.
Yes. We have not much experience on that. We have no many cases. I did it once with very nice results, but it's a very difficult situation. And what we are doing, said in the beginning, it's a very thin tube. And this helps us to avoid this kind of situation. We had, and also we don't perform Ivor Lewis. We perform an anastomosis. So we have a large thin and in those cases, it's very rare situation to have difficulty in gastric emptying. But I think that for those cases you presented, it's a good solution, and it established gastric emptying.
Well, and before continuing our discussion, I would like to go to the conclusion. And for us, we can see we can realize during this discussion that all surgeons we experience, or at least our patients experience, very annoying, very disabling consequences of nasophagectomy with the gastric tube due to the problem of gastric emptying. And it is not so severe as is in this case, but it is very frequent to see this kind of problems. And in the past, the problem when you had a gastric an esophageal cancer was to be cured of the cancer, and the quality of life was not at the at the first aim. Now we can obtain a long-term survival after an esophageal cancer, and the problem of the quality of life is becoming more and more common. We see that actually when we have no radical solution, either endoscopic or surgical, to prevent or to treat this problem of gastric motility, which are the consequences of the section of the vagus nerve, which is mandatory during the esophagectomy. Roux-en-Y solution, Roux-en-Y loop after an esophagectomy is may be a solution, but it is not. It doesn't work very well at any time. In some patients, it is very efficient, and some patients, as you have seen in our paper, some patients resume a normal quality of life, and some patients not at all. And even in one patient, it was total failure, and he was still very disabled by a problem of gastric emptying. However, we continue to propose it after several years of problem of in patients who are very uncomfortable, in patients in whom who are sure that there is no problem of cancer. And you see on a series of more than 700 Ivor Lewis, we performed it in only 9 patients. It can give you an idea of the rate of this kind of indications. This was my conclusion, and maybe we could continue our discussions with the audience.
Yes, thank you. I wanted to come back to my original comment, and that was I concede the patient is young, and she has a lesion, achalasia, that has a low incidence of squamous cell carcinoma, which she had. But I would submit if this patient had no achalasia and the same esophageal lesion, so same squamous cell carcinoma esophageal lesion, it's certainly conceivable she would be treated with radiation, maybe chemotherapy. If you go the opposite way, if on the basis of just achalasia, again, she doesn't have a cancer, I don't think an esophagectomy would be the first treatment of choice. It would be, she has type 2 achalasia, which responds better to all kinds of therapeutic interventions. And so I think, and I would ask the group to help me with my thinking, but at least a thought could be treat the lesion with radiation chemotherapy, treat her achalasia, which should respond, and then longitudinally follow her. And so I would submit that I congratulate the surgeons who presented this case, and they certainly got a happy, satisfactory ending for her. But I just, in my own mind, I had difficulty with the points I made. I'll stop and let anybody comment.
Thank you for this comment. And the decision of esophagectomy was for us according to the standard in Europe. And as I said before, exclusive radiotherapy is indicated only in patients who have a contraindication for surgery. And maybe now, after this difficult story, which probably has a happy end, maybe if we had knew all the problem we will face, maybe we would have proposed radiotherapy, but it is not a standard solution.
In my opinion, surgery remains a good option for those kind of patients because the esophagus is not healthy at the origin, meaning that you still have the functional problem of the esophagus. And in addition, if you had a cancer on achalasic esophagus, the risk is to have other tumor location. And as previously said by one of the gastroenterologists, it's a difficult endoscopic examination to do, and the problem is to miss, to go for surveillance on the cancer that you've treated with the chemoradiation, also to miss another small cancer. We had an experience a few years ago for a patient where we perform regular surveillance for an achalasic esophagus, and despite this surveillance, we missed the cancer. We made endoscopy every 2 or 3 years, and then between the two endoscopy, the patient developed a cancer with metastatic spreading. So I think I would go for surgery for those kind of patients.
Thank you so much for your comment, Guillaume. That's right, that surgery is quite a radical solution because we can treat both the cancer and also the achalasia. But I think that the comment of Dr. Johnson is really interesting because indeed it could be possible to perform radio chemotherapy and a very narrow surveillance with an early yearly fibroscopy, because we advise to have yearly fibroscopy for a patient with achalasia. And we know that radiotherapy may allow to perform a surgery if there is any recurrence. So I think that this could be also a possibility to perform radiochemotherapy with a good surveillance, a good follow-up.
I have to agree with this comment. Cancer in megaesophagus, it's a very rare disease. We have in more than 2,000 cases, we have just less than 2% of cases with esophageal cancer. And in the late follow-up, we have follow-up of more than 25 years. We don't have cancer in megaesophagus. The incidence is very low. So conservative management of megaesophagus is our first choice, even in very large esophagus. But as you said, we have to have a good follow-up and utilize endoscopy with dye. We utilize LUGO and MBI to perform a good endoscopy. When we wash the esophagus, we prepare it very well, and we have very nice results with that. So performing esophagectomy in all megaesophagus, it's a very difficult situation. I wouldn't do it. Conservative management, I think it should be the first choice for treated megaesophagus, unless we find a cancer. But it's a rare situation. It's not a usual situation in megaesophagus.
I do agree that it's a rare event. It happens in between 2 to 3% of patients. But I also want to emphasize that the frequent surveillance is the only thing we can do in patients with achalasia. There is no medication that works. So I think that that would be an approach. As far as the chemoradiation, it's also challenging to do because there's a significant degree of sigmoid reconfiguration of the esophagus or very significant degree of dilation. So what we do under those circumstances, we place fiducials, clips or whatever in the esophagus, which has been identified as having cancer in a particular location, identified by NBI or Lugol. And then we have a conversation with our radiation oncologist to see what they can do, having at least an established location of what they're going to radiate. It's very challenging for them because of the mobilization of the esophagus. In these cases, it's not as simple. And the accuracy of the radiation and defining the specific localization of the cancer can be a challenge.
Oh.
I thank the respondents for their comments. That was quite insightful. Thank you.
Are there some other comments or questions?
One comment is not a joke, but red wine helps against the development of cancer of the esophagus. So you guys are at a very proper place not to have too many cases.
Thank you. Well, Robert?
Well, I am so glad that this session will be, I am so glad that this session has and will be recorded, because I think this is really a model of the multidisciplinary sharing of knowledge carried on by ESO since the beginning of our organization. And I wish to, well, convey my warm thanks, to Denis Collet and Caroline Gronnier for the way they conducted this session. They should be congratulated for the choice, particularly educational choice of the case, which is a symbol, I think, of the scientific value of the esogastric pole that they direct now in Bordeaux by Professor Gronnier after Professor Denis Collet. They should be congratulated for the excellence of the presentation. They had prepared it very, very nicely, and they took all the necessary time, to show up exactly what was the interest of the multidisciplinary discussion of such a case. And they should be congratulated for the truly interactive way in which the discussion has been conducted. Of course, the contribution of panelists of the caliber of George Triadafilopoulos, dear George, of Guillaume Piessen with his experience in Lille, with all the papers they published from the department in Lille, with Richard McCallum and his experience in gastric motility. That's why I wanted him to participate and to be part of this interactive discussion. And of course, our old friend Bruno Zilberstein, all then they could give a sustained rhythm to the exchanges. And I thank them very, very warmly, not to mention the contribution of people from the audience. Peter Grimminger was there, and Larry Johnson, our dear friend, also very loyal to ESO since the very beginning of our organization. And to conclude, I should say that it seems now this was the 14th case discussion that we presented today. And I think that we can say that we have a new tool, maybe a new model on a given case with panelists of the caliber that were put together today. This will not replace our congresses, that's sure, but this will also certainly actively contribute to education in the field of esophagology. And we must not forget to provide also our warmest thanks to Frederick, because as customary, in spite of the slight problem that you may have seen at the beginning of the session, he succeeded in giving us the false impression that the whole running of the session we shared today was nothing but a very, very simple undertaking. That was my comment, and I would like to tell you that our next discussion will be held in a short time to preserve the Christmas break. It will be organized by the Pilot Center of Geneva with Professor Stéphane Menig and Dr. Chevalet. They will talk about very interesting cases of oligometastasis in esophageal cancers. This will be very interesting for us for this discussion that is scheduled for December 9. And I can tell you that the panel that they gathered for this occasion promises to offer a discussion that you will not forget. Be sure to attend also. And thank you to all of you. Thank you, George, for being here with us. Thank you, Guillaume Piessen. Thank you, Richard McCallum. And of course, Denis and Caroline in their place, and their place of Bordeaux.
Nice job, Denis.
Thank you. Bye-bye.
Bye.
Bye-bye and see you soon.
À bientôt. À bientôt le 9 décembre.
Bye-bye. Frederick, thank you.